Okay, good morning. Thank you for the kind introduction. So the topic of my presentation is cardiometabolic syndrome. Where do dermatologists fit in? And this is a very important question indeed. What is our role as dermatologists in the management of cardiometabolic comorbidities? And I would say that our role is very important and very central in the management of these comorbidities. We are not alone. We are not alone in this task. We should collaborate with other physicians and other specialities. But the truth is, for many patients, we are the main doctor or the only doctor of these patients. So we have the responsibility of at least to diagnose and to monitor the cardiometabolic comorbidities, to refer or treat the cardiometabolic comorbidities, of course to advise the patient to adopt healthy lifestyle behavior, and of course to treat the psoriasis effectively. Because as we're going to see, also the treatment of psoriasis may have a positive impact in cardiometabolic risk. This is my disclosure. So as we all know, psoriasis is more than skin dip. There are several comorbidities that have been shown to be associated with psoriasis, but cardiometabolic comorbidities are very prevalent and probably one of the main causes of morbidity and mortality in patients with psoriasis. And starting with a clinical case of a typical patient that probably all of us see in clinical practice. This is a 48-year-old male patient with severe plaque psoriasis with several comorbidities, hypertension that was not being controlled or well controlled, hyperlipidemia, not controlled with a statin, and diagnosed hypertriglyceridemia. He was an ex-smoker. He was quite obese and also with elevated liver enzymes, probably due to fat liver. And he has been previously treated with several conventional systemic treatments that have failed or have been stopped to intolerance, mainly due to worsening of his cardiometabolic comorbidities. So this is a typical patient with moderate to severe psoriasis. In this table, we have the baseline characteristics of the patients that were included in the ustekinumab trials back in 2012. So represents a typical population with moderate to severe psoriasis. And we see that the mean BMI was almost 31. Almost 50% of the patients were obese, 80% overweight, 36% of the patients had metabolic syndrome. And the prevalence of the other cardiometabolic comorbidities was quite high. And also these patients, or most of these patients, were not being correctly treated for their cardiometabolic comorbidities. So there is no doubt that these patients with psoriasis, with moderate to severe psoriasis, have higher prevalence of many cardiometabolic comorbidities. And this has been shown in several studies. I bring the data from some meta-analysis that clearly show that psoriasis is associated with increased prevalence and incidence of cardiometabolic comorbidities. The main consequence of this increased prevalence of cardiometabolic comorbidities is that these comorbidities contribute to the higher risk of cardiovascular disease and cardiovascular mortality that we see in patients with psoriasis, both mild psoriasis and severe psoriasis. And this has been shown in several studies. To better understand the magnitude of this association, I bring the data from 3 studies. The first one from the Danish nationwide cohort study that showed that the cardiovascular risk increase in patients with severe psoriasis was similar to that seen in patients with diabetes, that we all know is a well-known cardiovascular risk factor for cardiovascular disease. In another study, psoriasis patients were compared with type 2 diabetes, and again, a similar prevalence of moderate to severe coronary calcification between the patients with psoriasis and the patients with type 2 diabetes, and 5 times greater than healthy controls. And finally, another study, a very interesting study that compared psoriatic patients with a high-risk population, patients that were hyperlipidemic and also 10 years older. And again, it was shown that psoriasis patients had a similar coronary artery disease risk as this high-risk population. So clearly showing that psoriasis is associated with increased risk of cardiovascular disease. And why does this happen? Well, there are 2 main factors. Of course, the genetic background, environmental factors, they play a probably they play a role, but mainly the psoriasis-associated inflammation and the increased prevalence of the cardiometabolic comorbidities, in particular obesity, as we're going to see, are the main factors promoting, driving atherosclerosis and driving to cardiovascular disease. So if we want to improve cardiovascular health in our patients, it is important to act on these two factors, on psoriasis-associated inflammation and then on cardiometabolic comorbidities. Obesity is probably the main comorbidity in psoriasis. It's important influencing psoriasis, but also a very important comorbidity influencing cardiovascular disease and all the other cardiometabolic comorbidities. And this is due to the fact that the adipose tissue, mainly the visceral fat, is an active immune and endocrine organ, and obesity is associated with a low-grade chronic inflammation. So an inflammatory state due to the increased levels and production of pro-inflammatory cytokines that are important in psoriasis pathogenesis, but also important for cardiovascular disease. So the obesity-related inflammation is important in development and worsening of psoriasis, and of course promoting atherosclerosis and cardiovascular disease. Also interesting is that other forms of adiposity may also be important, not only abdominal visceral fat. We showed some years ago that psoriasis is also associated with increased epicardial adipose tissue, independently of visceral abdominal fat. Epicardial adipose tissue is a visceral fat that surrounds the heart and the main arteries and produces inflammation locally, so increasing the risk of cardiovascular disease. So it's probably another important contributor for the higher cardiovascular risk in patients with psoriasis. And then there's inflammation. Inflammation is probably the link between psoriasis and atherosclerosis. Atherosclerosis is an inflammatory disease. Inflammation is important in all phases of atherosclerosis. And it's probably, and the psoriasis-associated inflammation and atherosclerosis share several common immunologic mechanisms. So it's probable that the psoriatic inflammation also promotes atherosclerosis. So treating psoriasis, as we're going to see, may have a positive impact also in decreasing the risk of atherosclerosis. And several studies have shown this, including studies using image techniques like PET-CT and PET-MRI that showed in patients with psoriasis there was inflammation beyond the skin, in several tissues beyond the skin, including vascular inflammation. That is a marker of systemic inflammation and also a marker of atherosclerosis. And how have we, as dermatologists and as medical community, dealing with this issue? Unfortunately, not so well. I bring the data from several studies, and several studies have shown, including a recent one from 2018, that show that there is a high prevalence of undiagnosed and undertreated cardiovascular risk factors within severe psoriatic patients. And this is probably due to the fact and due to the low awareness and also low proactivity by the physicians that contact with patients with psoriasis, dermatologists, but also GPs and cardiologists that do not routinely screen cardiovascular risk factors in these patients, probably to the low awareness of the association. Some years ago, we made a nationwide study in Portugal to evaluate the awareness and the management of cardiovascular risk factors in patients with psoriasis by Portuguese dermatologists. And we found that 12% of the dermatologists had no knowledge about the association, and 40% did not contribute to the management of these comorbidities. So clearly, it's important to improve what we are doing with our patients regarding the management of cardiometabolic comorbidities. So what should we do? So what should be our role as dermatologists? Well, first, we should screen and monitor the comorbidities of our patients. We should follow the guidelines. There are several guidelines, but at least we should follow the guidelines for the general population, so the general population guidelines for cardiovascular risk estimation or for the management of cardiovascular risk factors. We should at least check for blood pressure, for the lipids, for the risk of diabetes, and of course check the weight at least once a year. Then, if in patients with comorbidities, we can treat the comorbidities. If we feel comfortable treating these comorbidities, we can start treatment for blood pressure, for the dyslipidemia. But if we don't feel comfortable, we should refer the patients for treatment, for the GP, for the cardiologist, for other specialties that can treat the comorbidities of these patients, the cardiometabolic comorbidities of these patients. Very important, and we may play a very important role in this task, is counseling our patients to adopt healthy lifestyle behaviors. We all know that we have limited time in our appointments, but this is very important to advise our patients to do physical activity, to lose some weight through diet and physical activity, to reduce or stop smoking. This is a very important task that we should be performing. And then, of course, to adequately treat psoriasis, because treating psoriasis will probably decreasing systemic inflammation, and we are probably decreasing the risk of cardiovascular risk, as we're going to see. At least with methotrexate and biologic agents, this has been shown. Well, weight loss should always be one of our recommendations in patients with increased weight. It has been shown that decreasing weight is associated with improvement of psoriasis and psoriatic arthritis, improvement of metabolic profile of the patients, and also improvement of the efficacy and safety of psoriasis treatment, in particular conventional systemic treatment. So weight loss is very important. Another way to improve the management of cardiometabolic comorbidities is increasing patients' awareness through education. We studied the impact of educational sessions on cardiometabolic comorbidities. We made an observational study to evaluate the impact of an educational session on the knowledge among patients about the association between psoriasis and cardiometabolic comorbidities, the importance of lifestyle changes, the management of cardiometabolic comorbidities. And the results were very interesting. We noticed, we found that the knowledge was really low before the session, but 6 months after the session, 60% of the patients started or increased their level of physical activity, 50% of the patients lost some weight, and 50% of the patients cut down on smoking. But also very interesting, 90% of the patients that were at the educational session, they consulted their GP to screen or monitor their cardiometabolic comorbidities, and there were new diagnoses of comorbidities that were not diagnosed, and also some therapeutic adjustments. So some comorbidities were not being correctly treated. So these educational sessions had a real impact on patients' health. So it's another tool that we can use with our patients. Just 2 slides to talk about the possible impact of psoriasis therapy on cardiovascular risk. Well, there is increasing evidence that treating psoriasis, mainly with methotrexate and mainly with biologic agents, may decrease the risk of cardiovascular disease, showing to improve several markers of cardiovascular risk, including vascular inflammation. There is also some observational studies showing that treating patients with methotrexate and with biologic agents may decrease the risk of cardiovascular events. And this very interesting study from 2019 showed that treating with biological therapy, we may change the coronary plaque components, so improving the morphology of the atherosclerotic plaque. So like a direct impact of the biological therapy on atherosclerotic plaques. So we also have to treat our patients correctly. We'll be improving the quality of life, of course, of our patients, but also probably we are decreasing in part the risk of cardiovascular disease. Returning to our patient, the patient started adalimumab with a good clinical response, no side effects. Recommend the patients for healthy lifestyle behaviors, some diet, some physical activity. We optimize the treatment of cardiometabolic comorbidities, and the patient made his role a very difficult role. He reduced his weight a lot, 40 kilograms in 6 months, and the patient is now controlled for his psoriasis and also most of his cardiometabolic comorbidities. So the main take-home message is that patients with psoriasis have a higher risk of cardiovascular disease due to the psoriatic inflammation and also to the increased prevalence of cardiometabolic comorbidities, mainly obesity. It's true that the awareness that psoriasis is not only a skin disease has been growing among dermatologists, but there are still many patients that are not being diagnosed or treated for their cardiometabolic comorbidities. And finally, we as dermatologists may play a very important role in the global management of these patients. In many patients, we are their only doctor, screening, monitoring, or treating or referring for treatment, the cardiometabolic comorbidities. Very important, recommending the patient to adopt healthy lifestyle behaviors, and of course, properly treating the psoriasis activity. Thank you very much.
Thank you very much indeed for a fantastic talk. We've got our panel discussion collectively, but are there any key questions to Tiago just to start? I'll make one comment though. I'm mightily impressed about the impact of your educational awareness program in terms of changed behavior. Is there something special about your intervention?
Yeah, well, we study an educational program with 70 patients that were attending. We made specialized presentations with the language for patients, explaining the importance of managing their comorbidities, and we had these results. And now we're doing once a year educational session, one morning, talking about psoriasis, several topics, but we always talk about cardiometabolic comorbidities. So with these results, we feel that probably every year we are improving the education of our patients, and we think that we are also improving the management of the cardiometabolic comorbidities.
And were the patients who took part in that program, was it a selected group of people who were interested, or was it to everyone?
Well, we invited patients for our clinic, and only appeared the patients that wanted to be.
Yes, so perhaps, yeah, that maybe that is partly contributory to your very good outcomes.